Good afternoon, dear doctors and colleagues from Southeast Asia, and good morning to our speaker and colleagues from Europe. I am Audrey Castro from Philippines, and I am privileged to welcome everyone to this live webinar on the management of osteoarthritis with a focus on symptomatic slow-acting drugs. To facilitate our discussion, we have our moderator, who is an expert in the field of rheumatology. She is a professor in the Division of Rheumatology, Department of Medicine at the University of the Philippines College of Medicine. Doctors and colleagues, please welcome Professor Bernadette Hazel Manapat-Reyes.
Good evening to everyone. As introduced, I will be your moderator for this symposium. We will only have one speaker for this symposium, and I shall be introducing him presently. There is a Q&A box at the bottom of your screen that you can use to type in your questions anytime during his lecture. Our speaker will be answering your questions after his talk. Let me now introduce our speaker, Professor Olivier Bruyere. He's currently Professor of Clinical Epidemiology in the Department of Public Health Sciences and of Geriatric Rehabilitation in the Department of Sports Sciences of the University of Liege in Belgium. He's head of the Research Unit in Public Health, Epidemiology, and Health Economics in the same university. The research unit is a WHO collaborating center for public health aspects of musculoskeletal health and aging. His main fields of interest are prevention, rehabilitation, and epidemiology related to geriatric conditions and musculoskeletal disorders. He's author of more than 300 international scientific publications and book chapters. I'm sure he's a very familiar name to those of you who follow developments in osteoarthritis. So let us welcome Professor Bruyere as he discusses the management of osteoarthritis with a focus on symptomatic slow-acting drugs.
Thank you very much, Professor Reyes, for this very, very kind introduction. So this is my privilege indeed to discuss with you the management of osteoarthritis with the focus on the symptomatic slow-acting drugs in osteoarthritis. Of course, I would like it to be in a face-to-face meeting with all of you from Philippines, Malaysia, Thailand, Indonesia, Hong Kong. But unfortunately, I'm only in Belgium, Europe, in a very cold weather. So, but indeed, it's my privilege to share with you online this talk. So I've got, of course, some competing interest for this particular talk, and especially I received some remuneration from Ireland, but please also have in mind that I've got also other competing interests. I receive some research grant, consulting fees or lecture fees, but also, and I think it's important, we can discuss it later on, I'm also the CEO of the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Disorders. It's SKO, and as you will see, I will share with you some of the data that we have produced in this non-for-profit organization. So I will, of course, discuss with you osteoarthritis, and I think it's very important to discuss osteoarthritis because it's the most common form of arthritis. You know from your clinical practice that it affects thousands of people. It is characterized by many joint disorders with a lot of functional decline, a reduced quality of life, and according to very large epidemiological studies, osteoarthritis has been suggested to be one of the major contributors to global disability. And I would acknowledge that I was quite surprised by that. But if we look at the increase in the number of years lived with disability, we can see that we have observed an increase in such number of years lived with disability in the last few decades. So clearly an increase in the prevalence, an increase in the incidence, and consequently a decrease in the health-related quality of life of our poor patients. I would say that the excellent news is that we have some effective treatment to manage osteoarthritis. It could be a pharmacological intervention, but also non-pharmacological intervention. And I would say that the excellent news is that we have recent guidelines for the management of osteoarthritis produced by the ORC, produced by the American College of Rheumatology, produced by our society, so the European Society, so SKO, and we have also many national guidelines and excellent recent guidelines. And I would like just to share with you one of these guidelines, and this is an algorithm for the management of knee osteoarthritis. And I think I really like this algorithm because it provides a step-by-step approach in the management of osteoarthritis. So that could be really of practical interest for many clinicians. And if we look at our algorithm, we've got a basic principle and some core sets of therapies that we will discuss in the next slide. But then we have 4 different steps according to the stage of the disease, according to the pain of the patient, according to the persistence of the pain of the patient. So the first step will be the background treatment. The second step will be the more advanced pharmacological management. Then we have the third step with the last pharmacological attempts. And then, of course, we have the end-stage disease management. If we start with the basic principle and the core set of therapies, the basic principle is very simple. And here we should acknowledge that we agree with all guidelines published during the last 2 decades, is that we need to have a combination of pharmacological and non-pharmacological therapies. It has been shown to be highly effective, so much more better than if you use only pharmacological or non-pharmacological. Of course, we have also some core set of therapies, including information and education, weight loss is overweight, and exercise program. You are obviously aware that information and education are of primary importance for our patient. It has been shown in many clinical trials that an education of the patient just to better understand the stages of the diseases or just to understand why a pharmacological intervention is important or why weight loss or exercises are important. It's very important for the patient because it could also improve the compliance to pharmacological and non-pharmacological. Of course, weight loss if the patient is overweight is a very powerful treatment. There are some clinical trials showing that if you lose some weight up to 5%, you are able to improve your pain up to 20%. So it's not that bad. You can improve the quality of life of the patient just with a reduced weight. And of course, we've got also the exercises program. And I would say that the excellent news is that we've got, of course, many different exercises, resistance training, aerobic exercises, a combination of these exercises, or even other exercises, whole body vibration, sports, Tai Chi, and so on. And it's very important to have in mind that all these treatments have been shown to be effective to decrease the pain of the patient, to improve the function of the patient, and to improve the quality of life of the patient. And a very nice editorial was published, I think, last year, and the title was provocative. The title was, "We do not need any more clinical trials assessing the effect of exercises on osteoarthritis." Why? Just because we know that exercises are very powerful to improve the quality of life of the patient. And what you need as clinician to have in mind is that whatever you are prescribing, it will be interesting for your patient. Of course, you know also from your clinical practice that probably that resistance training or aerobic training should be prescribed differently according to the characteristic of your patient, according to the preference of the patient, according to the stage of the disease. But clearly, you can also have in mind that the preference of the patient is very important, and whatever the exercises performed by your patient, it will be useful for the patient. So once again, very important to have in mind that exercises, weight loss, education are core set of therapies that must be given to the patient in order to improve their symptoms. Of course, we know that it's usually not enough for some patients to control the symptoms. And in our algorithm, we propose to have a referral to a physical therapist, of course, to control for malignment, but also to try different treatment modalities to improve the function of the patient or to reduce the pain of the patient. And for example, it could be some thermal agents, some manual therapy, some taping, some aquatic exercises, some Tai Chi exercises. And we know also that if it's performed by a physical therapist, we will also have an improvement in the quality of life of the patient. So clearly, we recommend the help of a physical therapist to have a full control of the symptoms of the patient. Once again, we could imagine that in some case it's not enough to have a full control of the treatment, and then we need to start the first pharmacological attempt. And at the level of SKO, we recommend the use and the chronic use of symptomatic slow-acting drugs in osteoarthritis, and it's especially the case of prescription-grade glucosamine sulfate or chondroitin sulfate with the use, if needed, of paracetamol. I think that it's quite different of the recommendation published a couple of years ago by other scientific societies or even by our own organization, the SKO. And if I come back to in 2014 with our first algorithm recommendation for the management of osteoarthritis, at that time, we recommended as a background treatment also the use of long-term paracetamol use. It was mainly because it was recommended by other scientific societies, even if at that time we acknowledged that the effect of paracetamol was probably very low. And I presume that you, as a medical doctor, you have already observed that the effect of paracetamol to improve the quality of life of the patient, to decrease the pain of the patient, is probably quite limited. We already know that at that time in 2014, however, since 2014, we have new data suggesting that paracetamol is not as safe as we thought before. And that's, for example, the meta-analysis and systematic review of observational studies published a couple of years ago, suggesting that a long-term use of high doses of paracetamol could increase the mortality of the patient. And so once again, that's why at the level of SKO, we downgraded the interest of paracetamol as a long-term use and as a background treatment in paracetamol. So of course, we can still recommend paracetamol, but over a short-term period with low dose of paracetamol. And let's be clear, we are also in agreement with most of the clinical guidelines published recently by other international or national societies. So if I come back to the chronic use of symptomatic slow-acting drugs in osteoarthritis, we've got, of course, different symptomatic slow-acting drugs: glucosamine sulfate, chondroitin sulfate, diacerin, avocado soybean, and saponifiables. Let's be clear, we have probably more data for glucosamine and chondroitin, and we need to have in mind that we could also have, even among this potential treatment, some important differences that I would like to discuss with you today. And I just would like to take the example of glucosamine sulfate. And in our SKO algorithm, using the grade recommendation as requested by the World Health Organization, so using this grade assessment of the best treatment modalities, we have a recommendation of the use of prescription crystalline glucosamine sulfate as the long-term background therapy and discourage the use of other glucosamine preparation. And I just would like to discuss that further with you, because once again, we need to differentiate different glucosamine products. And you know that we have glucosamine, but glucosamine in itself cannot be used because it's very unstable, and we need to stabilize it in order to use it in clinical practice. And we have different salts of glucosamine. We could have the glucosamine hydrochloride, and it's mainly used in over-the-counter products. We could also have different glucosamine sulfate, glucosamine that have been stabilized with different things. And we have, for example, the use of glucosamine hydrochloride with an addition of sodium sulfate. So it's called glucosamine sulfate, but I call it glucosamine sulfate because probably that we need to have a strong stabilization, and a strong stabilization has been obtained with the prescription grade crystalline glucosamine sulfate. So let's be clear, it's just chemistry. It's not really my field, and my field as a clinical epidemiologist is to see if there's different formulations of glucosamine sulfate or different glucosamine could have some different effects in the human. And I just would like to start with one very interesting preclinical analysis, having assessed the effect of glucosamine to reduce the expression of different joint degradation mediators. It's the MMP3 and ADAMTS5. And this study was very interesting because this study was able to show that we need to have in the body a concentration of glucosamine of around 10 micromole of glucosamine sulfate in order to have an important decrease in the expression of these joint degeneration mediators. So keep in mind that basically we need to have a concentration of glucosamine in the body, in the plasma, of around 10 micromoles. And if we look at different formulations of the glucosamine given to different healthy individuals, and we look at the concentration in the plasma of glucosamine, we are able to show that it's only with the prescription grade crystalline glucosamine sulfate that we have a concentration of glucosamine of around 10 micromoles. And by the way, it's much more important that the concentration that we could observe if we use the glucosamine hydrochloride. So once again, we have some data here suggesting that the concentration of glucosamine obtained with the prescription grade crystalline glucosamine sulfate reach the range of 10 micromole of glucosamine in the body needed to have a decrease in the expression of potential unhealthy joint mediators. Once again, the question for me as a clinician epidemiologist is that how does it translate into a clinical effect in the joint? For that, we could, of course, review all clinical trials published in the field of glucosamine, but we have many clinical trials. Even if I just look at the meta-analysis on glucosamine, I've got 21 meta-analyses having assessed the effect of glucosamine or different glucosamine in osteoarthritis. Of course, I cannot share with you all these meta-analyses, and I have decided to share with you two of them. The first is an independent meta-analysis having assessed the effect of glucosamine on the symptoms of osteoarthritis. And it was very interesting because they have decided to assess the bias and the quality in the clinical trials, but also assess different brands of glucosamine, so different formulations of glucosamine. And what are we able to observe? It's very interesting because among all clinical trials having assessed the effectiveness of different glucosamine preparation, we are able, or the authors, they are able to show that it's only with the prescription grade glucosamine sulfate, so the brand of Rotafarm, Mados, now Mylan product, that we have a significant effect to reduce the pain of the patient. If we use other brands, glucosamine sulfate or the glucosamine hydrochloride, we have no significant effect at all to decrease the pain of the patient. So once again, suggesting that the formulation, the preparation of the glucosamine sulfate is of primary importance, and highlighting here the importance of the the use of crystalline glucosamine sulfate. We should acknowledge that in this particular analysis, even if we just take into account the prescription-grade glucosamine sulfate results, we have some kind of heterogeneity. And you can observe, for example, that we have some highly significant effect and less significant effect. But if we look in sensitivity analysis of this meta-analysis at only studies with low risk of bias, so probably the high quality trials, these sensitivity analysis show that it's still with the prescription grade crystalline glucosamine sulfate, so the brand of Rotafarm, Madoz, Mylan product, that we have a significant effect to reduce the pain of the patient. And even with the high quality trial, if we use other labels, so glucosamine sulfate or glucosamine hydrochloride, we have no significant effect to decrease the pain of the patient. So once again, highlighting here in the high quality trial that the preparation of the product is of primary importance. The second meta-analysis that I would like to share with you is a meta-analysis showing the effect of pharmacological treatment over at least 1 year period. And here also we have some very interesting data suggesting that it's only with the glucosamine sulfate that we are able to have a long-term control of the symptom and a long-term 1 year, 2 year, 3 years control of the symptoms, mainly with a reduction of the pain of the patient. And if we still have in mind the long-term treatment, you are probably aware of this Princeps trials published now 20 years ago, but still up to date, showing the long-term effect on the natural history progression of the disease. And you are obviously aware that we are able to assess the joint space width over time using a classical X-ray. And using a classical X-ray, we are able to have a look at the joint space narrowing over time. So the joint space width change over time. And using placebo, so it's the true natural progression of the disease, we observe a decrease and a loss of joint space width of around 0.1 millimeters a year. However, in patients taking crystalline glucosamine sulfate, we have no progression of the disease, so no joint space loss, no joint space narrowing, suggesting that it could translate into a structure modifying effect of the treatment. So using crystalline glucosamine sulfate, we are able to reduce the natural progression of the disease. Once again, I'm a clinical epidemiologist and I would like to know if it could translate into other health benefits. And I'm very happy to share with you this slide published more than 10 years ago, but I like it because it was my PhD thesis, and I worked on the 3 years trials having assessed the effect of glucosamine sulfate on knee osteoarthritis. And my idea in my PhD thesis was to see the patient 5 years after the end of the 3-year trial. So we have a 3-year classical randomized controlled trials, and I decided to see the patient 5 years after the end of the trials. And just have a look, after 5 years, at the number of joint replacement for knee osteoarthritis. And very interestingly, we were able to see that we have less patients from the previous glucosamine sulfate group that have experienced total joint replacement compared to placebo. So it means that we have more patients in the previous placebo group that have experienced some joint replacement, suggesting that the effects on the structure, the effect on the symptoms observed during 3 years could also translate into a health benefit even 5 years after the end of the trials. And I think it was a very interesting and powerful analysis. Of course, if at the level of the European Society we recommend the use of symptomatic slow-acting drugs, it's also because it's an excellent, they all have an excellent safety profile. And I just would like to share with you a paper published last year by our group. It was a meta-analysis of all randomized placebo-controlled trials, and we also use data from full safety report obtained from the pharmaceutical industries. And so we have a look at all adverse events with all symptomatic slow-acting drugs. And basically, they all show that we have an excellent safety profile of most of the symptomatic slow-acting drugs in osteoarthritis, except maybe with the diacerin where we have some diarrhea. But for the other symptomatic slow-acting drugs, we have an excellent safety profile. And I just would like to share with you the data that we have here with glucosamine sulfate. I just would like to highlight once again that at the level of SKO, we recommend the prescription-grade glucosamine sulfate or chondroitin sulfate. Why? But it's very clear. It's that because when you use other supplementation, and I just take here the example of a very nice study having assessed the effect of glucosamine or chondroitin supplementation on symptoms of osteoarthritis. And when you use just over-the-counter products or food supplementation containing glucosamine or containing chondroitin, you have no effect at all. Once again, highlighting what we have observed in the meta-analysis of Erickson, with no effect at all with other brand, so glucosamine hydrochloride. So once again, please keep in mind that we do not discuss, we do not recommend here various over-the-counter product or food supplementation. And once again, I just would like to highlight one of our previous publication, and clearly we noted in the conclusion that it seems likely that all other complex molecule class at symptomatic slow-acting drugs, the recommendation to the only formulation clearly supported by the evidence-based should apply. So I think it's important for you as clinician to only prescribe and give to your patient treatment where we have some clinical data showing a clinical effect. I think that it's the evidence-based medicine to use products where we have clinical data showing that this particular product is really effective for the management of osteoarthritis. Let's move now to the rest of the SKO algorithm. And of course, that sometimes for some patient, and you know that from your clinical practice, that physical therapist, exercises therapy, and even some background treatment with glucosamine is not sufficient. And at the level of SKO, we recommend the use of topical NSAIDs because it has been shown to be effective at least over a short-term period, and maybe also because of the excellent safety profile of this topical NSAID. So for a short-term period, probably that topical NSAID could be very interesting. And from the scientific literature, we are not able to recommend one particular topical NSAID. Of course, if the patient is symptomatic, we need to go to other pharmacological treatment. And that's the point where we propose, as proposed by other scientific societies, the use of oral NSAIDs. Of course, you are obviously aware that the NSAIDs must be given according to the safety profile, according to the clinical characteristics of the patient, and especially we could give different oral NSAID according to their gastrointestinal risk, cardiovascular risk, or even renal risk. But keep also in mind that we do not recommend a very long-term use of oral NSAID, but maybe an intermittent use of oral NSAID, mainly because of the safety concerns. So probably that in patients with high level of pain, with some kind of inflammation, you can give some oral NSAID, but please, and you know that from your clinical practice, that if you give some oral NSAID for 1, 2, or 3 years, it could be highly problematic. And by the way, most of the oral NSAID clinical trials are 3 to 6 months trials only. Of course, if the patient is symptomatic, we recommend at the level of SKO to give some intra-articular injections of hyaluronic acid or corticosteroids. We know that the effect size of these two treatments are very, very high. So some strong effect of hyaluronic acid, with the advantage of hyaluronic acid is that 1 or 2 injections could have an effect up to 6 months. And the advantage of corticosteroid is that we have a rapid action. So probably that in patients with high level of pain, with high inflammation, maybe that corticosteroids could be of potential interest for our patient. We also recommend at the level of SKO, especially as the last pharmacological attempt, the short-term weak opioids, because once again, it has been shown to be effective. However, you know that once again from your clinical practice that we could have some safety issues. So once again, you should pay some attention regarding that. And maybe that we have now some a sustained release formulation that could improve the safety profile of the patient in order, once again, to improve the compliance of the patient. And at the level of SKO, we also recommend duloxetine because in some particular countries, we use it. Personally, in Belgium, for example, it's not widely used. I do not know if in Southeast Asia it's also used. I do not know that, but clearly in some countries it's used, and we have some data suggesting that duloxetine could also be of potential interest for the patient. And at last, of course, that if the patient is still symptomatic after all these different treatment, and if the patient has poor quality of life, but for sure the surgery is needed. And clearly we have many data suggesting that total joint replacement is very effective. The improvement in clinical symptoms is very, very important. And of course that if the surgery is contraindicated, you need to go for stronger opioid analgesics. So my first conclusion is that we have an algorithm for the management of knee osteoarthritis with a basic principle, the combination of pharmacological and non-pharmacological treatment, a core set of therapies with the education, weight loss if it's overweight, and the use of exercises program. And then the first step with the background treatment, mainly with the help of physical therapists, and then with the first pharmacological attempt with the chronic use of symptomatic slow-acting drugs. Then we have the use of topical NSAID. If the patient is still symptomatic, we propose to move to the step number 2 with a more advanced pharmacological treatment with oral NSAIDs or with intra-articular injection of hyaluronic acid or corticosteroids. Then the last pharmacological attempts with the short-term weak opioids, and then the end-stage disease management. So my conclusion is that osteoarthritis is a major public health problem. The good point is that we have many excellent and effective pharmacological and non-pharmacological management to improve the quality of life of the patient. They all have included in many recent clinical guidelines. I think that the huge advantage of the recent guidelines compared to guidelines published in the last decades is that we have now some step-by-step approach in the management of osteoarthritis. And I just would like also to highlight that SKO recommend the use of symptomatic slow-acting drugs, especially the prescription-grade crystalline glucosamine sulfate as a background treatment. We discourage the use of other formulation or of combination using the other formulation of glucosamine or glucosamine hydrochloride. I just would like, before answering your question, to highlight one very recent data that we had from yesterday. And by the way, it was a pharmacoeconomic analysis that we have performed in the Thailand context. So basically, we have assessed using all glucosamine formulation found on the Thai market and taking into account the effect of all glucosamine available in the scientific literature. So we have performed some pharmacoeconomic analysis, so what we call some cost effectiveness analysis. So we have the cost of the different formulation of glucosamines available in Thailand. We have also the effectiveness, so in terms of quality adjusted life years that we are able to find in the scientific literature. So we are able to make the cost per quality adjusted life years, so a cost effectiveness analysis. And I'm very, very happy to share with you that in the Thai context, so taking into account the threshold of 100,000 Thai baht for the threshold of the cost effectiveness ratio, as recommended by the health authorities in Thailand, only the prescription grade crystalline glucosamine sulfate has been shown to be cost effective compared to all other formulations that have not been shown to be effective, even with this low cost effectiveness ratio. So once again, it highlights the interest of symptomatic steroid drugs. It highlights the interest of the prescription grade crystalline glucosamine sulfate. And once again, the results obtained yesterday morning only, once again, highlight my last slide with the recommendation for the use of prescription grade crystalline glucosamine sulfate. I just would like to thank you very much for your attention.